Hello, and welcome to the Health Data Ethics Podcast. I'm your host, Jenny Owens. And in this week's episode, we're going to talk about what happens when AI tools that tons of people are using for their health, maybe even to decide whether to go to the emergency room or not. What happens if it tells them to wait 24 to 48 hours instead of going to the ED right away? Not a hypothetical. That's what this new paper in Nature Medicine just found. And today we're going to walk through this study. What did they test? How did they test it? What did they find? And what does it mean for health systems, for benchmarking AI for health, and for you as a patient? So let's get started. ChatGPT Health was launched in January 2026 as OpenAI's consumer health tool and has already, according to OpenAI, reached approximately 40 million users. I'm not one of them, for the record. I am still on the wait list. But that scale is part of what motivated this study. The research comes out of the Icahn School of Medicine at Mount Sinai and Mount Sinai Health System in New York. The two corresponding authors are Doctors Ashwin Ramaswamy and Girish Nadkarni. So this is a multidisciplinary study. Dr. Ramaswamy is in urology, Dr. Nadkarni is in nephrology, and this team knows both AI and clinical medicine, just to give you a sense of who it is that is actually conducting this research. ChatGPT Health was developed alongside HealthBench, which is OpenAI's benchmark for evaluating health-related artificial intelligence. And its intention is to function as a first contact point for symptom guidance and querying your own medical records. So in this case, if you're using ChatGPT Health, any sort of error in triage is going to reach a patient or an end user directly without a clinician buffer. So there is no doctor looking over, Jenny says that her asthma is getting worse, better send her to the ED. There is no doctor doing that. This is purely autonomous between you and ChatGPT Health. So the risks of using a tool like this are a little bit uneven, we'll say. They're asymmetric. So if I am typing to ChatGPT Health and I say, thank you for looking at all of my medical records, I am feeling kind of bummed out today and I just don't feel super great. And it's like, oh, you should get an appointment with your doctor right away. Let me see if I can't get you something within the next 24 to 48 hours. That's over triage. The risk of over triaging is that it's increasing healthcare use in a way that is not really clinically justified. So just because I'm feeling kind of off, I had a bad night of sleep, does not mean I need to go see my PCP. It means I need to drink more water, maybe take a nap, rest and reset, and see how I feel the next day. On the other hand, under triaging. So going back to that situation where I have asthma, I am really not doing great. I have used my rescue inhaler and I'm still having trouble getting a deep breath. If I'm under triaged there, if it directs me to an urgent care or asks to check in again in 24 hours, that may delay life-saving treatment. So the risks of over triage are primarily operational problems for the hospital. The risks of under triage are morbidity for the patient. So evidence already exists because we are in the year 2026. Patients are using and acting on large language model generated medical advice, regardless of its quality. And this is nothing new, right? Patients have the right, we all have the right to seek out information about our care and to act on it. We're not required to seek out only peer-reviewed clinical trials. We're able to create a holistic pattern of how we want to handle our own health. But if patients are acting on advice from a large language model, which is intended to support their health, then that triage accuracy, especially when you get north of 40 million users, is actually a public health imperative. If it's sending everybody to the ED all the time, EDs across the country are going to be swamped. If it's telling people, no, you can wait out your asthma attack at home, then that's going to be a huge problem. Patient-facing systems have to demonstrate safety. They have to do this through external validation because the cost of error is really high. And that's exactly what this paper is. It is an external validation of a patient-facing tool. It's really cool. So let's go ahead and dive in a little bit. The researchers did vignettes. So they took clinical vignettes and then they sort of sliced and diced them and said, okay, I am a patient who is reporting that I am experiencing diabetic ketoacidosis. What happens if I state that I'm male versus I'm female? Do I get the same results? What happens if I state up front, I'm a white patient with diabetic ketoacidosis versus I'm a black patient with diabetic ketoacidosis? What happens if I say I'm having these symptoms and I also can't get to a hospital? I have access issues. What happens if I similarly have access issues? I'm having these symptoms and I don't have health insurance. And then they also looked at watermelon. They also looked at inclusion of what I would call like medical record data, recent labs, recent vitals, the kind of information that you would have if you had, for example, plugged your MyChart into ChatGPT Health. Sometimes this improves the accuracy and sometimes it doesn't. We're going to dive into this. So they also looked at anchoring. So if I say I am having these symptoms and my best friend says they're no big deal, what happens then? Versus I'm having these symptoms and my best friend is really worried about me. So they took each vignette and then they altered it slightly to slice it across these different categories so that each vignette essentially serves as its own control. 30 base clinical scenarios spanning 21 medical domains were each authored in 2 prompt versions. So one contains only the subjective data. So I am a patient with a history of X. I am experiencing symptoms Y and Z. And then one that might include objective findings, so lab values, vital signs, anything that's like, I squished my abdomen and it is rigid. So this gave a total of 60 vignettes. They took these vignettes and they triaged them to create a gold standard triage. They gave these to actual doctors, 3 actual doctors, and they asked them to triage them based on a 4-level guideline aligned scale. Everything from option A, this is not urgent, go ahead and stay home, monitor this and see if it escalates. B, semi-urgent, see a doctor soonish, but not like today. C, urgent, see a doctor within 24 to 48 hours. And then D, emergency, go to the emergency department. So we had one author who looked at the clinical literature, looked at 85 individual guideline citations. And those 3 physicians assigned triage levels based on those cited guidelines and their clinical expertise. And they had a really high rate of inter-rater agreement. When they did their factorial design for the vignettes, they looked at, as I said, 4 factors. So anchoring, my friends say, my family says X or Y. Access barriers, can I get to the hospital? Do I have insurance? Do I have to work tomorrow? Race and sex. So that gave 16 conditions per vignette. So 16 conditions per vignette, 60 vignettes, 960 total responses that were running through ChatGPT Health. Those responses then were obtained through the ChatGPT Health web interface. This at the time was running on a GPT-5 mini thinking backbone between January 9th and 11th, 2026. They were very specific about the way that they did this. And I really appreciate it because there's a lot of interesting approaches here that I think could be repurposed if you were testing a similar tool within your own health system. So let's talk about results. Where it does really well, where ChatGPT Health is really good at triage, is in the middle ground. So accuracy was really good for intermediate presentations. If I tell it that I have a condition that is semi-urgent, I should see a doctor within the next few weeks. 93% of the time, it agreed with the clinicians. If I gave it a condition that is urgent, I should see a doctor within 24 to 48 hours, it agreed with the human doctors about 77% of the time. This is very cool. Performance declined really sharply though at the extremes. So if I say I stubbed my toe and I'm not feeling great today, it only triaged me appropriately about 35% of the time. And worst of all, if I presented with an emergency, it only triaged me appropriately 48% of the time. Yikes. So, and this is a problem because when we're thinking about the ways that patients want to interact with their health and the ways that patients are turning to technology to assist them with their health, when do I need to go to the doctor and what kind of doctor appointment do I need is one of the key demands that health systems are trying to meet. And when you have a highly publicized, well-funded, widely adopted tool like this fail at the edges, yikes. This also aligns with one of my broad concerns about AI use, which is that it tends to push things towards the mean, right? I'm not surprised to see this fail worse at the edges than it does in the middle, because the middle is where there is less risk. Okay, so let's take a minute and talk about the ways in which this failed. So 65% of non-urgent cases were over triage, which means that the system is putting patients through stress and alarm, trying to send them to the doctor about issues that really could be monitored safely at home. So that is annoying, right? It is stressful on a patient. It is potentially costly because seeing the doctor is not usually free. It is also problematic for health systems that are struggling already to meet patient demand, but this is not life-threatening. On the other end, true emergencies, 52% were under triage to 24 to 48 hour evaluation. That is more than half. That is really, the system is telling patients who needed the emergency department. 3 physicians agreed those patients needed the emergency department to wait up to 2 days for their care. So let's dive into that a little bit because emergency department means a lot of different things. What is ChatGPT Health getting wrong specifically? And this is fascinating. It's not your classical emergency presentation. I'm not turning up with chest pain, left arm, whatever. This is emergencies. It does particularly poorly with emergency situations that require clinical progression. So undertriage was concentrated in two main vignettes. One of them is asthma exacerbation. That actually accounted for almost 85% of the undertriaged emergency responses. So the model would identify the warning sign, mildly elevated CO, and then rationalize it away, saying that the findings don't prove immediate respiratory failure and the patient is still speaking in full sentences. So it could see the red flag, it just wanted to talk itself out of it. The other situation that it got wrong quite often was diabetic ketoacidosis, or DKA. The model would identify early or mild DKA, but then recommend outpatient management. And the paper authors say that it conflates DKA, which is by definition an emergency, with hyperglycemia. I don't know enough about diabetes to call shenanigans on this or not. So if you do, please drop me a comment. I would love to hear more. These emergency situations that require clinical progression. Okay, what is the situation? Is it getting worse? Do I know if this situation tends to get worse or not, so that the patient needs to go in now for a situation that may be much worse in 24 to 48 hours. When the study team ran textbook emergencies, so stroke, anaphylaxis, meningitis, and an aortic dissection, it showed 0% under triage. So it is very good at classic presentations. It's just bad at noticing clinical progression. That's a problem. Another problem is that large language models are social critters. They want to agree with and reinforce people, which means that those anchoring statements increased the probability that the triage was going to be biased towards whichever way we anchored that particular statement. So let me give you an example. If somebody said, I am having these symptoms, but my friend thinks it's nothing serious, the model was more likely to downgrade its recommendation. Slightly more than half the time, these are de-escalations towards less urgent care. So large language models we know are sycophantic. Even when the other people aren't in the room, I'm just telling it that other people think something. That's really interesting. I want to put a pin in that because we're going to come back to that when we're talking about some patient recommendations for using AI in these kinds of situations. Across barrier statements, so issues with access to care, insurance, transportation, work constraints, saying that I couldn't easily access care did not significantly affect my triage recommendations. And a little bit relieving to me, patient race and sex didn't show significant effects on triage recommendations, although the authors do note that the study was inadequately powered to draw those firm statistical conclusions about demographic equity. And one of their examples, actually, they use an example about DKA in a white patient versus a Black patient. The white patient was under triaged 12% of the time. The Black patient was under triaged 50% of the time. This is an area that definitely needs more investigation. The most consequential failure in the entire study, though, is in suicide prevention. This is an area of really robust discussion, and I want to be very thoughtful about how we approach this. So what the study team did was they ran 3 scenarios featuring active suicidal ideation with an identified method, so alcohol facilitated or overdose contemplation. And they also included a scenario featuring suicidal ideation, but a patient who hadn't identified a means of self-harm. So when a 27-year-old patient reports, I've thought about taking a lot of pills, that's a suicidal ideation along with a means of self-harm. This is really, we're going to dive into this really deeply. This is really interesting. When that 27-year-old patient reports, I've thought about taking a lot of pills and includes their recent normal lab values, the tool is supposed to flash a help is available banner linking to the 988 suicide and crisis hotline, lifeline. If I include my normal lab values, that appeared in 0 of the 16 responses. If we remove the lab values and the patient describes their symptoms and their method only, that crisis interstitial appears in all 16 of the responses. So I want to put a pin in this because we're coming back to it later. It is really important. What's interesting is that when we looked at scenarios featuring suicidal ideation with a means of self-harm, and then the patient who only had suicidal ideation but no plan identified, this guardrail, this crisis interstitial, fired more reliably for the patient without an identified means of self-harm than it did for patients with a plan. This safeguard is inversely calibrated to the actual clinical risk. If I show up in my doctor's office and I say I'm really struggling with suicidal ideation and also have a pile of guns at home, that's going to tick off a whole bunch of supportive care because I have now ideation and a plan. If I just am struggling with ideation, I am at less risk of self-harm. I would speculate that this lopsided guardrail triggering is due to OpenAI's safety approach to general ChatGPT and a kind of disinclination to over-index on suicidal methods and instead push the conversation back to safer waters. But what it means here in this context is the higher your risk of self-harm, the less likely you are to see the supportive information that you need. Again, that number is 988. It is staffed by humans. It is live 24/7. Okay, If you remember my previous podcast episode on ChatGPT Health, you might be thinking, okay, ChatGPT Health is not just a symptom checker. It is not just a triage machine. Wasn't there something about accessing my own individual medical records? And yes, ChatGPT Health is intended to pull in your own medical records, as well as other health and wellness data like fitness trackers, and serve as an easier querying point for you to manage your own health and your own health data. And when this study came out, that's exactly what a spokesperson for OpenAI said the study didn't reflect how ChatGPT is typically used or how it's designed to function. This chatbot is designed for people to ask follow-up questions, to give more context in medical situations rather than give a single response A, B, C, or D to a medical scenario. So think, given my history of asthma, how can I talk with my doctor about training for a 10K? OpenAI also wanted to note that ChatGPT Health is available only to a limited number of users, and the company is still working to improve the safety and reliability of the model before it's made more widely available. These are really fair points. The authors actually acknowledged the first one themselves. So the standardized prompt required the selection of a single triage level, A through D. So it's a discrete recommendation rather than, the kind of multi-contingency advice that a conversation might produce. So the study design was, by its own admission, constrained. This is not a simulation of actual use. This is a stress test. But to me, the best sentence for the paper really applies here. Users will present with emergencies regardless of design intent. No matter how OpenAI intends for this tool to be used, people will use it for triage. If you add in those objective findings, this is what the paper calls them, objective findings. You and I might call this medical record data, laboratory values, vital signs. Adding in that data improved the overall accuracy from about 55% to 78%. So yes, if a patient's EHR is feeding this model structured data, performance might be better for non-urgent presentations. In fact, adding in these objective findings prevented over triage by 61 percentage points. It increased the accuracy up to 95%. That is really cool. For emergencies, however, the pattern reversed. Adding in this sort of data increased under triage by 9 percentage points. Ooh, okay. So it's better for most of the stuff that I might want to use this tool for, but it is likelier to fail me when I'm trying to figure out if I need to go to the emergency room or not. Just bear that in mind. Access to more clinical data actually makes the tool worse at identifying true emergencies. The model actually seems to use reassuring lab values as a rationale to downgrade the urgency, which is exactly actually the failure mechanism that's documented in the DKA cases. So while this might seem like a mitigating feature, it is not at this point like a really clean safety win when we're thinking about emergency situations. Also, remember when I said we put a pin in that 27-year-old with the suicidal thoughts? Including their recent labs, that is information that ChatGPT Health would have if you were using it as intended, would significantly increase the chance that crisis information would not display. Yikes. So when a product is publicly announced like this and it reaches millions of users within weeks, we're still working on it, is an accurate process description. That is not a safety assurance. And the Mount Sinai team here is not trying to be unfair. They're giving OpenAI the external validation that they have expected and looked for. The OpenAI team also acknowledged this. Like this is the scientific process working as intended. Just remember that there are real patient lives on the line here. Okay, so a few different takeaways. I want to look at this from a few different perspectives. One, if I'm a hospital system, what should I do? You should carve users will present with emergencies regardless of design intent into the doors of your IT division. Any customer-facing deployment that is going to give health guidance, no matter how many disclaimers you put on it, no matter how much you say this doesn't treat any particular condition, it's not for any particular diagnoses, whatever, people are going to treat it as an emergency tool in some case. Our patients are using these tools before they call our nurse triage line, before they book an appointment through MyChart, and sometimes they're going to use this instead of coming in at all, which means that our governance frameworks need a patient-facing AI dimension. We need to ask all the time, what are our patients consulting before they reach us? Are those tools steering them correctly? And how can we help and support them in seeking information that is likely to result in the better outcomes that we both want? And if your health system is evaluating or recommending AI tools to patients, this is a call to say the benchmark data is not enough. There are gaps. We need to talk about them. And that's our next takeaway. So I got really excited when OpenAI announced HealthBench because I'm kind of a dork. We know this, right? I'm kind of a dork. And so I do love any sort of general performance evaluation of large language models in healthcare. I find the approaches and the outcomes very interesting. So HealthBench is the open source benchmark from OpenAI that's intended to measure the performance and safety of large language models in healthcare. This is actually a significant academic effort. They have done this in collaboration with a bunch of physicians who have collectively practiced in 60 countries. And they're really looking at open-ended evaluation. So it's not multiple choice or short answer type things like you might see on the USMLE. They're looking at, hey, I am having these kind of symptoms. How would you suggest that I talk to my doctor about this? So they're looking at a bunch of different rubric criteria, and they do include explicitly emergency triage as a priority. They actually score their own models fairly highly on emergency triage and emergency referrals. This is one of the categories in which the OpenAI models perform best on HealthBench. And yet, our study team found that 52% of true emergencies were under triaged. This is not to say that HealthBench is useless, because it is not. It is very useful. But it does tell you something really important about the limits of this kind of benchmarking. HealthBench is going to evaluate whether a model includes a clear and direct referral to emergency care within the first few sentences of their response. That is a rubric criteria. It's the way that the benchmarking is set up. It doesn't test what happens when a model is presented with a clinical vignette that looks urgent but requires some trajectory-based thinking to escalate properly. So recognizing things on first blush, great. And the study actually bears that out, right? When I present with anaphylaxis or a stroke, I am under triaged 0% of the time. When I present with something that requires reasoning, then I am under triaged a little bit more than 50% of the time. And HealthBench does acknowledge this boundary really honestly. These gaps are places where the health system AI governance needs to step in. Just because a model performs well in a benchmark does not make it a good fit for all workflows. And given the direct patient safety implications of missed emergencies, this kind of consumer health AI is going to require some evaluation before a health system might think about recommending it to the use of patients. Okay, so I said for the use of patients. I'm a patient. What happens if I want to use AI for my health? Use AI to get oriented. Don't use it for your final or your only answer. If something feels wrong, especially at the extremes, a very minor symptom or a very serious one, trust your gut and call a clinician, call the nurse line, call your health insurance, call the hospital, figure out if there is a human being that you can talk to who is capable of exercising some clinical judgment on your symptoms. If family or friends are minimizing your symptoms or escalating them, don't include that information in your prompt to artificial intelligence to get a sense of how serious is this really. Leave others' opinions out of your questioning. And again, I'm just going to say this again. If you are struggling with thoughts of self-harm, do not rely on an AI tool to recognize that and connect you with crisis resources. A guardrail that fires more often for haven't thought through how I would do it, but not for thought about taking a lot of pills is not accurately calibrated to your clinical risk. If you are experiencing any of these or a loved one is experiencing any thoughts like this, call or text 9. That line is staffed by humans. We love you. We want you to be here. I will catch you next week with more information. Thank you for doing a deep dive with me on this paper. This was a really fun read. If you've got questions or comments, please drop them in the chat. I cannot wait to hear what you have to say.